Something that we did in our study is that we actually validated the tumor reactivity of each of the neoepitope-specific T cells that we isolated, because we also had tumor cell lines from each of the patients. So what we saw is that the neoepitope-specific T cells that we isolated, we were able to take the TCR, clone it, and express it into healthy donors, and then assess the reactivity against the melanoma cell lines that we had established from those patients. So we know that these neoepitope-specific T cells are actually tumor reactive. And so by the fact that we saw in patients that do not respond to immune checkpoint blockade, we were still able to isolate these neoepitope-specific T cells and clone those TCRs. We could potentially now use the patient white blood cells and collect them ex vivo and then modify them to actually express these neoepitope-specific TCRs, expand them into large numbers, and reinfuse them back into these patients. So by basically forcing the expansion of these tumor reactive T cells ex vivo and infusing them back into the patient, we could potentially be able to develop the immunotherapy for these patients that do not respond to regular immune checkpoint blockade therapies. And that would be the clinical application of the studies that we are doing, and more in terms of research and understanding. We are creating a big set of TCRs with matched cell lines that are going to allow us to understand which are the characteristics of the TCRs that are better suited to achieve higher anti-tumor response. So we are trying to characterize the phenotype and the activity of these TCRs and how they modify the signaling inside the cell to be able to select better TCRs for adoptive T-cell therapy.